Okay. Now, Dr. Jayadev told me we should go for multiplex. Anyway, we'll go for influenza or respiratory panel full. Yes, Dhiren, आप इसमें influenza करोगे या respiratory panel
Sir,
करोगे?
admitted patient, I go for full panel, and
Absolutely.
OPD patient, I treat empirically.
If we have so much of a differential diagnosis, better to
sir.
go for full panel.
Yeah, if admitted, if OPD basis, I treat empirically.
And especially it's a long duration and nephrotic syndrome. So
Okay,
better to
okay. So, advantage of this will be that most respiratory infections are similar in presentation. A syndromic panel will help to diagnose the cause. And these are the panels available. I won't discuss in detail. They have been discussed by Dr. Tapisha in the afternoon. And then the report comes adenovirus. Okay. And should I trust it? कर दे सर ट्रस्ट करते हैं ठीक है एडिनो ही है ये yes anyone should I trust it
Yes, in the context of the
अब वो कहते हैं they
patient's
can be a
presentation.
bystander it could be a common cell कर दें इस पर ट्रस्ट कर दें
No, in the context of the patient's presentation or in the positive report and the sensitivity of the report, we are okay to trust it.
blood culture came negative yes doctor
you see some organisms are not commensals. So that you have to judge. If it's a say human metapneumovirus and all that, then you can think that it might not be pathogenic. You might doubt. But if it's an adeno, if it's a mycoplasma, if it's a pertussis, then definitely even an upper respiratory sample, you have to give it some importance.
does this correlate there are first two things to correlate one is epidemiology because if such cases are occurring in the community I will suspect yes this could be again adenovirus this is why how we diagnose in our day-to-day practice now can I relate this clinically with this patient seen this scene this is a summary of the patient and does this PCR report of adenovirus correlate with the Dr. Jayadeep, I'll come to you because you have seen large number of cases during that epidemic in West Bengal.
Yeah, actually adeno might present in various ways. It might present with typical lobar consolidation, just like a pneumococcus. Sometimes it's also very mild. And I mean, you cannot just say that it can't be adeno. So adeno is all, but again, I must add, in such a circumstance, such a presentation with such a history, even if it's an adeno, then I don't think anybody will have the guts to stop antibiotics.
Okay, many times multiple viruses are detected. The problem is how do you differentiate this is a bystander, common cell or this is a true pathogen? That's the main question in our practice with this PCR. Now and nasopharyngeal viruses which correlate well with BAL and clinical illness, these are the bugs. Influenza virus, RSV, parainfluenza, metapneumovirus, adenovirus and COVID. If they come, you have to trust them but still correlate clinically. This is not 100%. You must correlate clinically. Okay, and high counts and CRP in viral infection, yes, it can happen in adenovirus. I think Dr. Tanu was also telling you the last lecture. It is a well-known feature of adenovirus. Okay. Now, we come to know.
Sometimes even in viral infections, right, it's necrosis of necrotic pneumonia. You can have very
because
well
adeno is well known for.
Even if it is not adeno, even in like influenza pneumonia, and if you find very high CRP, that is a marker of severity also. It doesn't mean always bacterial superadded, but I totally agree. It's there to stop antibiotic even if you know adeno is the cause.
Now, grandfather is admitted in Gangaram, and the BAL sample there is adenovirus, and elder sister is also suffering from respiratory infection, being managed from OPD. इसको भी investigate कर दें, Dr. Agarwal? इसको भी कर दें investigate?
Multiple person in the family, they are suffering from the similar illnesses.
इसके भी 20,000 खर्चने?
But if their symptoms are there, then only we will correlate.
I think if the patient is from the OPD, I think better avoid it. Treat it as, I think Dr. Sethi हमारे साथ होते थे panel discussion में.
You're talking about this patient?
No. I'm talking about the elder sister.
If she is symptomatic, then
Okay.
definitely we will consider to investigate.
No,
I-
unless symptomatic.
नो नीड
you go
एब्सोल्युटली
ahead.
नो नीड आई थिंक डॉक्टर सेठी होते थे हमारे साथ पैनल डिस्कशन में कई बार तो वो कहते थे दीज वायरल इन्फेक्शंस दे टेक अबाउट 7 days but you don't treat them or you don't investigate them they take 1 week so you can either way you can go for that okay should I investigate her no we won't investigate I think OPD practice may I discourage absolutely now should we continue oseltamivir no we
Yes,
won't
stop it.
continue okay now, this is 11 day of illness. After 48 hours of admission, the child's respiratory distress has worsened. The child is shifted to PICU. The patient is now BiPAP. XHS is almost same, Jaideep, absolutely. And will you escalate antibiotics here?
I think in this patient, we are talking about that adenovirus, right?
No, I'm talking to the, I've come back to the patient.
Yeah, come back to the. So in this patient, as a protocol, we send blood PCR, right? And so we look at the next 3-day course. If you find that patient is set, the disease is settling, we don't do anything because most of 99% of time, adenovirus do settle in immunocompetent unless it is multi-organ involvement other than
देख
immunocompromised.
ऐसा है
Because we considered this patient little bit immunocompromised, he was receiving steroid. So in this patient, depending on the severity, we will consider adenovirus as a serious bug. We'll send the blood for the copies and we'll think of cidofovir in these type of patients.
Okay, means the answer is if the child is worsening, in these cases, one protocol is to do DNA copies in the blood. If the DNA level reaches a threshold, in that we won't discuss in detail, in that situation, you will be giving cidofovir. Now, this patient had recovered from recently from kidney disease. So, nephrotic syndrome, although nephrotic syndrome doesn't damage the kidney a lot. But anyway, I was little considerate and then antibiotics not escalated obviously because that's the advantage of doing these PCR tests because you can practice your antimicrobial stewardship program also. And the treatment option Dr. Dhiren has given me should be given cidofovir. And Dr. Jaideep, I come to you. You have seen good number of cases. And what will you do in these cases? You will give cidofovir after doing DNA copy. DNA copy भी 2-3 दिन में report आती है, जल्दी नहीं आती है.
In such a situation, number one, I will definitely repeat a blood to see if there is worsening of the parameters. Cidofovir, yes, pending this report. And also with this background, I will escalate the antibiotic.
You will?
Escalate the antibiotic.
Okay. Now, how to treat such patients with progressive worsening? High viral load we know is known to cause known to be reason for the sustained viremia, and this could be predictor of a poor outcome in many studies. Give cidofovir or IVIG in this patient. What I practice myself is, I think, don't take this back home. What we do is, in cases where the DNA load is high, we give cidofovir. But in cases where DNA is hardly there, but the patient is worsening, we give IVIG. So this is sort of the principle we follow. And we gave IVIG in this patient, and patient improved in next 24 hours and was discharged after 5 days. So this was regarding one patient of adenovirus was worsening. But cidofovir, Dr. Dhiren, you can tell us your experience of cidofovir having used in adenovirus.
Yeah. We calculated it. I think in that given year, we gave cidofovir in 44 patients. And most of them were having multi-organ involvement and immunocompromised, but there were almost 1/3 immunocompetent patients where we found that disease was worsening. Like in this patient, we would have given cidofovir instead of IVIG. So we basically use cidofovir in these 3 circumstances.
Do you give
And
probenecid with the
we did
cidofovir?
not find any renal problem in any given.
Do you give probenecid also?
Yes, there's a typical protocol and we follow that.
Okay. Now I think the caution is if you are doing PCR, multiplex PCR, detection does not mean causation. Be careful. It will be colonizer, it could be bystander. Remember, PCR is detecting both dead as well as live bugs. There's a risk of contamination. And in case of biofire, luckily it's a closed system, there's no risk of contamination. Always correlate clinically and epidemiologically. And you got something unusual, be careful, and need to do these tests in only selected cases. Now, can we indulge as Dr. Anurag indulge? Okay. Now, this is second case. So we'll run through it very fast within, I think, 5 minutes so that we'll take this leeway of as Anurag took. Now this is 5 years, you took 10 minutes. Telling that there are 3 slides more, you should give us 10 slides. हमारे ही भाग गए थे, हमने धीरेन को पकड़ के ले आए. अच्छा, I think doors should be locked now. Okay, 5-year-old female child, 20 kg, fever is there for last 7 days. And this is a patient about, I think, 8-9 years ago. I think I could take it out because I thought even this is quite interesting today. And initially 101, 102 for 3 days, and now 103, 104 for 4 days. Admitted on day 5 in a local hospital, being treated with meropenem, azithromycin, amikacin for 2 days, and came to us on day 7 with fever, high-grade fever, vomiting, and markedly increased cough. So this was the presentation. So means if you take it from the face value, it looks like it's similar presentation, like viral, or it could be mycoplasma or something. Now it's also